Good afternoon, everyone. Welcome to the PCR webinar, Multivessel Disease in ACS, Which Lesions to Treat and When. I am Peter Smits from Paris/Rotterdam, and I'm here with two experts in the field. One is Simone Biscaglia from Ferrara, Italy, and remote we have Valeria Paradis from Rotterdam. We're going to discuss this interesting topic, and we have divided our webinar in certain chapters. We will first discuss complete infarct-related artery-only treatment. Second, we will discuss whether complete revascularization should be done physiology-guided or angio-guided, or imaging-guided versus angio-guided. We also will discuss complete revascularization in the acute setting or in the stage setting. We will also discuss different strategies in STEMI patients and non-STEMI patients. And if time allows, we will also have a peek into the future to look at what are the future trials. We have some learning objectives. Here we have again our speakers. And our learning objectives is to learn about new evidence for complete vascularization in ACS, to understand how to decide which lesions to treat, and to discuss optimal timing of complete revascularization. As an introduction, I want to show you one overview slide of all the landmark randomized controlled trials and the change in the guidelines in multivessel disease STEMI patients. And here you can see that really the guidelines based on all these trials has dramatically changed from a more or less a type 3 recommendation not to treat complete revascularization in acute setting towards a complete vascularization at index or within the first 55 days after the myocardial infarction. So that is an impressive change in our guidelines. Concerning the non-STEMI population, you can see here that the evidence is less robust. Many studies are a mix of STEMI and non-STEMI patients, and also the guidelines are not that well established or well supported with trials, but at least it is going in the same direction that complete vascularization should be considered when patients present with multivessel disease. So, having said that, I think it's time to start with our first question and our first topic. It's about complete revascularization versus infarct-related artery-only treatment. And I would like to ask our first speaker, Simone Biscaglia, who is the lead investigator of the FIRE trial, if you could tell a little bit more about what was the design of the FIRE trial and what were the main findings.
Thank you, Peter. Yes, of course I can. So the FIRE trial included patients with at least 75 years of age. So this is the first difference if compared to the prior studies. And for the same reason, we included both ST segment elevation MI patient and non-ST segment elevation MI patient, because patients with older age are more prevalently hospitalized because of non-ST segment elevation MI. The third inclusion criteria was the presence of multivessel disease at coronary artery angiography. After the successful treatment of the culprit lesion, and therefore the culprit lesion had to be clearly identified by either EKG, angiography, echo, all the clinical tools we have nowadays, otherwise the patient could not be included in the non-STEMI setting. After the treatment of the culprit lesion, the patient was randomized to either physio-guided complete revascularization or culprit-only treatment. The baseline characteristics of the study mirror the patient population. Older patient, if compared to the other studies on complete versus culprit-only treatment, so 81 years was the mean age. Higher percentage of diabetic patient, 32%, higher percentage of female patient, because we know that female patients are more frequently presented for MI in the older age, and more complex patient in terms of KILIP class presentation. If we move to the results of the study, the primary endpoint was the composite of death, MI, stroke, and revascularization was significantly reduced in the physiology-guided complete arm with the number needed to treat of 19. The same goes for the main secondary endpoint that was the composite of CV death and MI. So these are the main characteristic and results of the study.
Great results and a beautiful study, definitely in a study that was needed to perform, but particularly because the elderly patients are badly represented in the current, in the previous trials, and I think it's an important question that you answered. I think many of us dealing with elderly multivessel STEMI patients or ACS patients probably would limit themselves to culprit only, and because of the age and comorbidities do you think maybe it's best to do that strategy? So Valeria, a short question. How did this impact your practice?
Well, thank you, Peter, and good afternoon, everyone. I think the FIRE was added one piece of information to all the results we have up to now, supporting the benefit of complete revascularizations versus culprit only, even in patients in elderly patients. So I think that's another piece of information which support and has been indeed incorporated into the guidelines, giving class 1 recommendation for complete revascularization.
Good. So a question for Simone. You did this physiology guided, and you used different techniques. You used FFR, IFR, and QFR. So FFR, IFR, I think after the Sweetheart and the Defined Flare, I think you can say very comparable in the majority of but QFR compared to the invasive strategies of physiology assessment, how much is the evidence?
Yeah, so exactly, Peter. What was done in the trial was to perform the physiology according to physician discretion and clinical use. So if they have QFR or IFR or FFR, they could use it, and the decision was at the operator level. So the investigator decided which kind of physiology to use. It was not randomized between different types of physiologies. Having said that, what we have seen by comparing patients who received one type of physiology or the other, because in the FIRE trial, 35% of the patients received QFR, 50% of the patients received FFR, and 15% of the patients received IFR, RFR, resting indexes. And what we saw was no difference across different physiological tools. So obviously, it's not a randomized comparison, but it's a kind of reassuring regarding the safety of QFR in the setting on non-culprit lesion of ST segment elevation MI. Obviously, we need more data and in a randomized fashion to confirm these preliminary results.
Okay, good. So for me, everything was clear up to March this year. Yeah, you presented your FIRE trial at the ESC 2023, and everything, all the trials so far showing that complete revascularization is beneficial for your patient on hard endpoints. So, and then we had at ACC this year the full revasc study. That really is kind of a brick in the water, giving some waves. What is your impression? Maybe you can tell a little bit about the full revasc.
Yes. First, I would like just 1 minute to show you a typical case of the FIRE trial study, so that we can get into the discussion of the full revasc, because this is actually a patient with non-ST segment elevation MI, so typical FIRE trial patient, because 65% of the patient were non-ST segment elevation MI. And basically the baseline angiography, you can see it from the slide, shown an intermediate lesion on the LAD. So typical case we can find in everyday clinical practice. Left circumflex was not so relevant in terms of distribution. And again, you see a clear culprit lesion on the RCA. And this is really important in non-STEMI settings, because as soon as you can clearly define a culprit lesion, then you can use physiology. But if you cannot, please don't use physiology in culprit lesion of ACS. So this was what was done in the FIRE trial to treat the culprit lesion with PCI. You see the final result on the RCA. And basically the clinical question we wanted to answer was actually what to do, for example, on this intermediate lesion on the LAD. What the investigator decided to do more frequently in the non-STEMI setting was to perform a wire-based, not a wire-based, yes, an invasive physiology. In this case, it was a microcatheter-based physiology with the pullback, because with the microcatheter, it's actually easier because you have your wire down to the vessel and you go back and forth with your microcatheter as it is with the balloon. So you can perform FFR by the estimation of the single point, but also perform the pullback. And you can see from the pullback here that you have actually two focal step-ups at the level of the two lesion, intermediate lesion before and after the diagonal. So taking this information into account, the operator decided to perform stenting across the diagonal with a provisional approach and post-dilation. And again, what they decided to do was to perform post-PCI FFR, because since you are there with the wire or with the microcatheter, it can be meaningful to understand whether you obtain a good result or not. In this case, post-PCI FFR was 0.90, so actually good. With right now, we have data showing that it can be different if you treat the LAD versus the other coronary arteries for post-PCI FFR. So for example, for the LAD, you should aim at 0.86, whereas for the other vessel, you should aim a little bit higher, around 0.90. But in this case, actually, we were quite sure that we obtain a good result in terms of post-PCI FFR. To come to your question, obviously, we had many data showing the benefit of complete revasc in patients with multivessel disease compared to culprit only. We have the full revasc that was presented basically this year, showing actually no benefit of complete revascularization versus culprit only. And FFR was the physiological tool used in the study. Obviously, the first thing we have to notice is that if you compare the other trials and also the full revasc, age and the rate of CV death was actually low if you compare it to for example, to the FIRE trial, because in the FIRE trial at 1 year we have 7% CV death. The other studies, around 3 years mean follow-up, the rate of CV death was around 3%. For full revasc it was around 4%, but we had a longer follow-up, 4.5 years. So the risk profile of those patients is lower if compared to the FIRE trial. And if we go directly to the full revasc, we have to take into account that the enrollment of the full revasc was stopped after the publication of the complete trial, and therefore the original sample size was the percentage of the original sample size that was reached was 38%. So it's actually underpowered for the original sample size calculation. There was a new one, but actually we have to acknowledge that they started by enrolling 4,000 patients and they enrolled 1,500 patients. If you have a look at the single components of the outcome, there was a significant reduction in unplanned revascularization, and this probably makes sense because of the risk of the population included, and that what was different from the other studies is the higher rate of stent thrombosis in the complete arm. That was 2.5% versus 0.9% in the culprit-only arm, whereas in the other studies, we didn't see such a difference among the two arms.
And this was even FFR guided, huh? So can you imagine what it could have been when it was Angio guided,
yes,
for instance?
Absolutely.
Maybe. Okay, but it's quite indeed 2.5% is too high that we normally see, I think, in other trials. So this full revasc, will it change our way of thinking, Simone?
Oh, that's a very good question. I don't have the perfect answer. What I can tell you is that if we put the other trials into context, so you see in the top part of the slide, these are the FIRE trial results, so high-risk population. Please have a look at the cardiovascular death hazard risk. You see, obviously it was not powered to show the reduction in CV death, but the other risk was exactly the same of the one of the other trials combined into a meta-analysis. So basically the idea is we are quite sure that by obtaining a complete revascularization, we are able to reduce CV death, and I think that we have many data about it. What we don't know is how to obtain complete revascularization.
True. Okay, that's also maybe a nice step to our next chapter about how should we assess the non-culprit lesions, whether it should be angio-guided versus physiology guided. And to introduce this chapter, I have a kind of a provocative case. It's an old case, but I think it's still very, for this time, still for the discussion, I think very nice. It's a patient, 65-year-old, the usual age for the STEMI patients, presented with acute chest pain, diagnosed by the ambulance with an inferior ST-MI. This patient had, as many cases with STEMI patients, no previous complaints, was hemodynamically quite stable, was treated in the ambulance already and brought to the cath lab, where we saw when we always look first at the non-infarct related artery, we see here some moderate disease in the LAD, a kind of tandem lesion, one lesion at the septal branch and another lesion shortly after the second diagonal. Both, I think so, by visual estimation, around 50%. And then we have on the circumflex a significant looking lesion, focal lesion in the margin obtusus and some moderate disease in the posterolateral branch. Well, here you can see again the LAD with a tandem lesion and QCA identifying on the margin obtusus 67% and on the posterolateral 51%. Diameter stenosis. This is of course, the culprit vessel, an infarct-related artery. Here we have a severe lesion in the mid-RCA and an occlusion of the arm, the descending postural artery, which is probably the culprit. That was revascularized and eventually stented and post-dilated. And I also, when I treat an infarct-related artery, I always try to make the best. So I also treat during the index also the lesion in the mid-RCA, and the end result was, I think, quite nice, with still good flow. And yeah, this patient stable. The complaints reduced, you see the ST depression depressed, and then is the question, okay, how to proceed? Short question to Valeria, what would be your takeoff on such a case? Would you do this, what would you do with the non-culprit lesions on the left?
Well, I mean, for the non-culprit lesion, you can think about, for intermediate lesion, I think physiology still plays a role. Okay. And we have supporting it.
So you would go for physiology. Simone, what about you?
Yes, I think I completely agree with Valeria, and I think that for example, for non-culprit lesion in STEMI setting, I think that angiography-derived FFR could be an interesting setting because obviously you can use the projection you obtain during primary PCI and not to perform a second stage procedure just, for a physiological assessment. We have to collect more data, but I think it's an interesting way to go.
Okay, so I followed more or less the same approach. I did physiology, did an FFR on the LED, which was 0.82, and also an FFR on the margin obtusus, which was, to my surprise, 0.93. And I decided not to treat those lesions and discharge the patient quite soon with dual antiplatelet therapy and statins. And this patient was for many years uneventful. So then the question arises, and I would like to address that to Valeria. Physiology in the acute setting has been criticized quite often. What are your take-home messages on this?
We have to take into account that there are some limitations, especially when we perform invasive physiology. So with both hyperemia indexes and resting indexes, we have some discrepancy between the values that we get in acute setting, in the subacute setting, talking about 1 to 2 weeks after the index procedure, and in the chronic setting. However, when we look at results and we see that the discrepancy is about 0.02, then the question is, what's the prognostic impact of such a really little disparities between values that we get in the acute setting and in the chronic setting? So there's still room for a safe and reliable assessment of the non-culprit lesion in the STEMI setting.
Good. For Simone, so we see, and also you observed in your FIRE trial, that many lesions are not significant by physiology. What is your take-home message on this?
Yes, exactly. This is, as you can see from the slide, basically, we have across all the trials between 40% and 50% of non-culprit lesions that are basically assessed by visual estimation and deemed more than 50%, they are at the end of the day negative in terms of physiology. And we know that the adverse event rate of those lesions is actually very low. So it's safe to defer those lesions. And this actually, when it's done in one procedure, is helpful for the patient and for the organization, because you can have shorter hospitalization, and hospital length stay is important either for the patient and for the hospital organization, and spare patient basically repeated procedure just to perform a negative assessment. And this was actually something that was, if we have a look at the data of angio-guided complete revasc versus physio-guided complete revasc, we had two studies showing quite the opposite results, because we have the FLOWER MI study with more than 1,000 patients enrolled, but with a shorter follow-up, with actually lower event rate than expected, where FFR and angiography were actually superimposable in terms of adverse event rate. On the contrary, we have the FRAME MI, where both ST segment and non-ST segment elevation MI patients were included, with half the follow-up, but half the patient, but longer follow-up, 3.5 years. And I think that one of the most compelling differences among the two trials is the fact that in the FLOWER MI, basically all the patients received the staged FFR, 97%. So basically you lose part of the benefit of physiology, that is to perform less procedure and less invasive procedures, whereas in the FRAME MI, patients received the stage procedure only in 40% of the cases. So I think that if you do physiology, try to do something that is helpful for the management of the patient, and not to perform the same number of procedures that you would perform by angio-guided PCI. This is my take home.
Clear. There's a question from the chat. I think that's really nice to discuss now. It's a question: when will be the best time to do physiologic assessment in non-infarct related artery lesions? Index or 2 weeks, and should it be FFR or IFR? I think the last question we already answered, but go ahead.
Yes, so the idea is, I think that now in 2024, we can put the number of FFR, IFR, QFR, whatsoever into the context of more information that we can gather from physiology. For example, if you perform FFR and you are in the gray zone or near to the cutoff and you don't know whether you have microcirculatory dysfunction, measure it. You can measure it obviously if you have the wire to do it and so on. But if you have it, why don't you take the 2 minutes that you need to have the information regarding, for example, IMR or CFR. If the IMR is less than 25, you're quite sure that this value will be stable either on stage procedure or longer follow-up. If you have a very high value of IMR, then you can decide, put everything into context, also the type of disease. If you perform a pullback, for example, and you have a very focal disease, 0.81 with very high IMR, then probably in this case you can decide to stent the lesion, and whereas on the contrary, if you have a 0.79 completely diffuse gradient, then probably with PCI you won't be able to change much. So I think that we have to put all the data that we have together in order to decide on a patient-by-patient basis.
Okay, good. So you go for an extensive evaluation,
Yes.
and if you don't have this extensive evaluation, or you don't have the time to do it, and you want to stage it, Valeria, have you any idea how long we should stage? Then, if you want to do the physiology testing of the non-infarcted artery lesions.
We have data supporting that after 2 weeks, then the physiology assessment is completely reliable, 100% reliable, because all the mechanism of reduced response to adenosine, of microvascular compression because of in the remote area of the non-carpet lesion, then they will be solved in 2 weeks. So 2 weeks is the cutoff to say, okay, this physiology measurement is reliable. However, I still want to echo what Simone was saying, that we should consider this value not just as a number, but of course as a continuum of values, and put this result into perspective and think about how amenable is the lesion for PCI, what's the location of the lesion, what's the syntax score, putting all these variables together.
Clear. Thank you very much. I think there was one more question, but I think you already answered that, but very short answer. Is Angio ever good, just as good?
I can show it to you, basically. What we did in the FIRE trial was to perform QFR in a blinded fashion from the core lab in all the lesions in the culprit-only arm. So lesions that were not treated, non-culprit lesions that were left on optimal medical therapy. And what we saw is that QFR, in this case, because it was used QFR, was able to discriminate the prognosis of the patient at the vessel level, so the vessel-oriented composite outcome, but also in terms of other outcomes as CV death or target vessel MI. Again, it's not a randomized clinical trials, but it's the first evidence, and we are now performing the clinical trial to try to show whether this is true or not.
Okay, great. Okay, so maybe it's nice to step over to the next chapter on imaging guided. We have talked so much about physiology, but what about imaging? How supportive can that be? Of course, with physiology, we do only a hemodynamic assessment of lesion, but we don't detect any vulnerability or of the lesion. So, Valeria, is there do we have enough evidence to support an imaging-guided approach to treat vulnerable lesions?
Yeah, that's a really trendy question. I think the recent evidence from some trials, despite being in the setting of chronic patients, actually support preventive PCI for lesion having vulnerable plaques. However, these data are really limited, and I want to just underline the fact that we do not have data on preventive PCI for non-carpet lesion of STEMI patients. So just to summarize what we have discussed up to now, how to assess a non-carpet lesion severity, and we know that we have different technology, we can use them, but we have to be aware of the limitation of each. So for angiography, of course, we can have an increased rate of vasoconstriction and an overestimation of the non-carpet lesion stenosis degree in the acute setting. For FFR and hyperemia indexes, in general, we have a possible underestimation because of the blunted response to adenosine, and vice versa. For resting index, we have a possible overestimation because of an increased coronary blood flow at rest. But let's now jump into intravascular imaging. We haven't discussed it so far, because intravascular imaging can provide us with some important information about high-risk plaque. And the question is, can we identify vulnerable plaque? Well, the question is yes. And the next question is, how can we do that? So at IVUS, for example, we can identify plaque burden, and we know that large plaque burden is associated with adverse event. But we also can quantify the lipid content, for example, at NIRS, identify plaque morphology with visual histology. And OCT probably is the tool which provide us with the most information about not only plaque vulnerability, but also plaque progression. For example, the presence of a thin cap fibroateroma, this has been associated with a higher risk of events. And also the minimal lumen area, identified at both IVUS or OCT, has been associated with progression to an acute event. But how often do we find vulnerable plaque in a non-culprit lesion of non-STEMI patients? We do know from the sub-analysis of the complete trial that 2/3 of the lesions present thin cap fibroateroma, and so are considered higher risk of events. 50% of thin cap fibroateroma were found in an obstructive coronary artery. So there's a correlation between the angiographic severity and the higher risk of having a vulnerable plaque. However, there's also a low percentage, 20% of thin cap fibroateroma, which were found in the non-obstructive coronary artery. And probably the most important question is, should we look for vulnerable plaque? I mean, how does that impact on the prognosis of the patients? A few studies have attempted to find a correlation between the presence of vulnerable plaque and the incidence of MACE, the so-called natural histories study. And we see that some of them actually identify those lesions with a particularly high risk of having an event, up to 11-fold higher risk of an event at follow-up. However, among all these studies, the predictive positive value remain low, meaning that not all the plaque, despite having a full house of morphological high-risk feature, necessarily progress to an acute coronary syndrome. And we can make some consideration, of course, why is that? Well, of course, natural history study, they provide a snapshot of the plaque at that moment, but we do know that the plaque evolves, and also criteria of vulnerability can at a certain point stabilize. We also know that, for example, a thin cap fibroateroma is not the only mechanism associated with acute coronary syndrome, not only plaque rupture, but in 25% of acute coronary syndrome is a plaque erosion, the underlying mechanism of the event. And also the role of inflammation, which cannot be really studied with contemporary intravascular imaging, and not even with NIRS. And I also want to underline the fact that when we look specifically at the vulnerable plaque in the non-culprit lesion of STEMI patient, they do present a higher, more advanced atherosclerosis. They have more frequent some signal of vulnerability, for example, plaque rupture, microvessels, calcification, and the large layer. And probably the $1 million question we have now, should we treat vulnerable plaques? The question you asked me, because we do know that these plaques are at high risk of having an event, but not all of them will eventually progress and cause an event. when we discuss about treatment, we could think about lesion level treatment, so sealing the plaque at the local level, avoiding any systemic effect of any drug, having a short procedure, but exposing the patient to a higher risk of scent-related events, as well as higher short-term cost. And talking about studies supporting this preventive PCI in vulnerable plaque, I mean, data are so far quite limited. But we do also have data supporting strategies at systemic level, where we have, of course, a systemic effect, no risk related to the intervention, but also some issues related to side effects, to lower compliance, to increase long-term cost. And some data from randomized trial, such as the Huygens, Pacman, MI, have actually shown that we do have a reduction of plaque burden, of lipid content, and also of the thickness of the cap when we do an aggressive lipid lowering strategy. So I think that's the answer to your question, if we should look for vulnerable plaque and what will we do if we find them eventually.
Good. Valeria, we can detect the vulnerable plaques in our ACS patients. The question is indeed, what should we do with it? You show that some lesions have a high characteristics for late events, but the probability that it will evolve into events are pretty low. So how do we, if we defer those lesions, how is the data looking from the trials for instance, within your FIRE trial, Simona?
Yes, we have actually a sub-analysis of patient undergoing physiology, negative physiology, and performing NIRS. We are basically performing the analysis right now. So I will tell you a little bit more in a few months. But what we see overall is that the rate of adverse event in deferred lesion was low, even in the FIRE trial, especially in target vessel MI related events. So I would say that we have the same issue of the other studies, that we are able to detect those vulnerable plaques, but as you correctly said, also in the FIRE trials, those lesions were not always causing an event. It was quite rare as an occurrence.
Yes. So similar that we also find in our Compare Acute trial, where we did only the follow-up up to 3 years, and where we divert on FFR many lesions, and actually the natural history was quite benign, and I think we also have some data from the complete trial and from the NAMI pre-multi, showing also that those lesions were not that really those lesions that are highly significant stenosed and are the ones that have the highest event rate. Good. Treatment of vulnerable plaque. We switch now over to complete, acute, or staged. I think that can be a nice case for also a nice, maybe a nice demonstration of a case. I want to give the floor to Valeria. How do you decide, Valeria, when to do a complete revascularization in the acute phase, or whether you want to stage your patient?
That's also a really trendy question, because we do have two very recent trials which have investigated a complete in the acute setting versus complete in the stage setting. And they both show that immediate complete was non-inferior to a stage complete revascularization. So I would like to present you a case, a 72-year-old man with no cardiac history who presented with STEMI inferior. And that's the Angio. At the baseline, you can see there's it's a marginal branch with a really small caliber. And you see that in the LED, there's a lesion at the mid-level of the vessel, a significant 90% of lesion involving a bifurcation with a big diagonal, which also have some degree of stenosis in the mid part. And that's the culprit vessel. I mean, no doubts that with this really high thrombus load, we can easily identify the culprit lesion in the mid-right coronary artery. So the decision was to start, of course, with the primary PCI of the right coronary artery. In this case, we decided to perform thrombus aspiration because of the really high thrombus load. And you can see the result of the right side of the screen. So the patient was treated with DES for O and post-dilated non-compliant 4.5 balloon. This is the result, and you can see from a cranial view that there's some stenosis in the RDP. But I would like to stop now and examine all the non-culprit lesions that we have for these patients. So we have non-culprit lesion 1 in the RDP, is the lesion of the same territory of the IRA. We have an angiographically intermediate lesion, but also we can expect some level of vasoconstriction. We do have a non-culprit lesion 2, an osteomarginal, small caliber, angiographically looks significant, but how about vasoconstriction also for this lesion? And the non-culprit lesion 3, we have a bifurcation, LED with a big diagonal, Medina 111, also lesion in the diagonal, an angle which is not particularly favorable, similar caliber of the daughter side branches, and we could anticipate a 2-stance bifurcation PCI. So when we calculate the residual syntax score of all these non-culprit lesions, we end up to a syntax score which is 17. And I would like to put then my result for my case into perspective with the residual syntax score across randomized controlled trial. Just to underline the fact that, first of all, most of the trial up to now have excluded patients with the non-culprit lesion located into the left main, and some of them low percentage in the LED. But also when we look at the mean syntax scores for the non-culprit lesion, we see that for complete was 7.2, and for the biovasc, almost 90% of the patients had the residual syntax score of lower than 8. And the majority of this trial had just one non-culprit lesion treated, just to underline the fact that the majority of the trial investigated complete revascularization, and also the strategy when to complete the revascularization actually enrolled patients with not particularly high syntax score. Because, of course, when we decide to perform the stage revascularization of these patients, I mean, there were some consideration in order to optimize this procedure. So first of all, considering the not particularly relevant caliber of the RDP and OM, we decide to go conservative for these 2 non-culprit lesions. But when it goes to the LED, well, this procedure, with all these technical challenges, definitely require some strategy in order to optimize the procedure. So after gentle predilatation, an OCT was performed. And you can see here that we use the OCT not only to assess the lesion morphology, but also to identify the landing zone at proximal and distal area. So the strategy for the bifurcation, which was adopted, was a stepwise layered approach with a further Predilatation of the mid-LAD, implantation of the stent trio 28 pot with a non-compliance 3.5. And you can see the first pullback of after PCI, after implantation of the first stent. But also the first rewiring towards the diagonal in order also to acquire information about the lesion length into the diagonal at any kind of plaque shift. And you can see here that the minimal lumen area into the diagonal is particularly reduced, and also the lesion extended quite far into the diagonal branch. The OCT also guided into the rewiring in order to ensure that there was a proper rewiring, opening the stent struts towards the diagonal. And it was then decided to escalate to a two-stent strategy, a culotte technique, with implantation of a DES into the diagonal. You can see that the rewiring into the main vessel went quite easily. Final kissing balloon and repot. And this is the angiographic final results. And also from intravascular imaging perspective, control of good implantation of the stent, expansion, absence of malapposition, any distal dissection, also from the diagonal branch. So it's to underline that when we decide to perform a complex procedure, probably we do need to use all the tools that we have in the cath lab, and the idea of rushing the procedure into during the acute setting is not particularly appealing.
Good. Clear, Valeria. So your strategy is more or less, you look at the amount of the residual stenosis, the amount of the residual syntax score, the complexity of the non-culprit lesion, and then you make your decision to do it staged or acute. I have a question from the audience referring that. So suppose you have a very complex anatomy, and there's a question, how often do we still ask the surgeon to step in for urgent CABG in our ACS patients? Nice question. Maybe Simone, how often in your practice?
Very rarely. Yeah. In the ACS setting, especially ST segment elevation MI, we don't often ask the surgeon to complete revasc, or at least they don't often accept to do it. But yes, I think that in ACS, most of the cases are completed by percutaneous treatment.
Valeria?
Well, I think the role of a heart team is something we have to acknowledge. There are some patients, especially young patients, for example, with a left main or a really proximal LAD complex lesion, where surgery may still play a role. But of course, there are also some other challenges that the surgeon may need to face, for example, discontinuation of antiplatelet therapy.
Good. Considering your case, could you have considered to do a kind of a hybrid approach where we have the stent in the main branch and the DEB or DTB for the diagonal to limit the amount of metal in your case?
Very good point. Also because there are some ongoing randomized trial looking at whether DCB or DES into the side branch, what strategies is better between the two. But I think the lesion length into the diagonal, and also the caliber of the diagonal, actually steered my procedure towards a two-stent technique. Because we do know that when the lesion length in the side branch is longer than 10 millimeters, it's there's where we have a benefit of a two-stent strategy technique.
Excellent. Thank you very much. Good. So we have quite some evidence now on complete, acute, and staged. The data on the randomized controls very much in favor of doing things acute. Is there some bias there? Do you think selection bias or assessing? Simone, what is your take-off?
No, I think data is compelling, so we cannot, overlook them. But at the same time, for sure, for example, the definition of myocardial infarction may vary, because if you do it in the acute phase, for example, periprocedural MI is almost impossible to diagnose, whereas when you do the staged procedure at 45 days after the PCI, obviously you may have a higher rate of periprocedural complications, so this has to be taken into account. But I think that the overall message we can take home from those studies is that after an acute event, something may happen in the early phase, so don't wait too much. You don't have to do it always within the same procedure, but I think that it can be reasonable to do it within the same hospitalization, not to wait 1 or 2 months and then have another event on top of one that already occurred.
Okay. So Valeria, what about you? If you're going to do a staged procedure, what kind of optimal timing do you have in mind?
Well, I think we can look at some data from trials, and first of all, having an overview of all the possible strategies how to complete, and we do know that there's an overview of all the trials performed in the last decade, looking at different strategies. And very recently, we had the multi-stars and the BioVasc looking at immediate versus stage complete revascularization. But also for the complete trial, when we look at the stage versus culprit only, we see that there's an interaction, and that patients who received complete revascularization during hospitalization actually do better as compared to patients when complete revascularization is performed at later on, so after the first hospitalization. When we look at the data and we look at when actually is the best time window, we see that most of the trial actually decide 45 days as the time window to complete revascularization, but 6 weeks is quite a long time window. A lot of things can happen. And also when we look at the complete, we see that the majority of the patients received stage revascularization 1 day after the randomization, that the BioVasc, the median time was 14 days and the multi-star was 37 days. So there's a huge variability between the timing when the stage revascularization should be completed. My take is probably when we do it better, when we do it earlier, then we do the best for the patients. And I think now we can move to the last chapter for the non-STEMI.
Definitely. So we are coming close to the end of our webinar, but we have still one, I think, important topic to discuss shortly, and that is, are the STEMI patients and the non-STEMI patients two different animals? And should we adopt our strategies towards the different presentations? Who wants to take on this? Valeria, you would want to take... What is your take-off for non-STEMI and the STEMI patients?
For the non-STEMI and the STEMI patients, definitely we do have less data for non-STEMI patients. That makes the whole story more difficult to understand. And even when we look at the same trial, we look at the non-STEMI versus the STEMI cohort, there are some differences. For example, in the BioVasc, we saw that immediate complete was non-inferior to the stage complete revascularization. with even a lower incidence of MIs and unplanned revascularization for the immediate group. And probably these results were largely driven by the non-STEMI population, especially when we look at the timing when to complete in STEMI patients. Again, 6 weeks is a long time window. And the BioVasc actually showed that the majority of the events, of the MIs events, happened in the stage complete revascularization group between the index and the stage procedure. Also, when we compare the time window in the BioVasc to the SMILE trial, we see that it's basically double of time between the index and the stage revascularization. And there's one important difference between the non-STEMI and the STEMI. Besides all the problems, the issue related to the patient and plaque vulnerability, that the non-STEMI patients actually have the challenges of misjudgment, potential misjudgment of the culprit lesion, and also the possible presence of multiple culprit lesion. And also, when we look at a longer term, midterm follow-up from the BioVasc, we see that at 2 years, there was no difference treatment in immediate and the stage complete revascularization for both non-STEMI and STEMI. But when we look at the non-STEMI subgroup, we see that there's higher incidence of the primary outcome at a landmark analysis between 1 and 2 years. So probably we can conclude that what we gain in the first phase during the in non-STEMI patients in the immediate revascularization strategy, then we actually sealed all the potential culprit lesion. That is something that we lose in the long term because we rush into a procedure and we do not optimize the procedure. In fact, the use of imaging and physiology in the non-STEMI subgroup of immediate complete revascularization was lower as compared to stage complete revascularization group.
And yeah, this Valeria, just if I may, 30 seconds to add, just to to reinforce your message, because what we found in the FIRE trial was that complete revascularization had to be obtained within index hospitalization in both STEMI and non-STEMI patient, and was guided by physiology in all the cases. So actually, this goes into the way you were alluding to. So we did not find any interaction between clinical presentation and the results of the study, but by doing such a strategy, so completing within the index hospitalization and with the use of physiology in all the cases.
Clear. So if I summarize this very shortly, for STEMI and non-STEMI patients, you might think you might do it in a stage fashion, but if it is complex, but then do it in an early, very early phase, if to summarize it completely. So very good. I think it's also nice to have a short peek. What's the future gonna bring us? And Simone, can you go shortly over the several things that will help us in the near future to answer some remaining questions?
Yes, Peter. So we discussed regarding the fact that complete revasc is the way to go. We still don't know probably which is the best way to go. But the good news is that we will have soon, you see, many studies on the topic comparing either angiography complete PCI versus physiology, or versus wire-based physiology, or versus angiography-derived FFR, or versus IVUS or OCT. So we will have in a few years basically much more data and information to guide the treatment of our multivessel disease patients.
Perfect. And just to mention, all those trials we are not talking about ACS patients in shock.
No.
What we discussed today and what is also on this slide for future trials, it's all about non-shock ACS patients with multivessel disease. I think having said that, I think we come almost to the end. We have one last minute. I think we can thank you very much for your great presentations and your great comments. I also would like to thank the people in the chat that asked us some nice questions. I would like to reserve the last minute to go over our take-home messages. And if I can have I will go to the last slide. So actually, this is the ESC guidelines. I don't think that things at the moment have changed so much, except for in our STEMI patients, that we can do the complete vascularization during the index or within, at least during the hospitalization, or at least within the first 45 days. Doing it at the index, if the complexity is not too high, it seems to be safe and very much doable. Some like multi-stars even showed that it could be even, in certain cases, could be even beneficial. I think the most important thing is that complete revascularization is something to do irrespective of age. I think that's important to mention. Whether it should be angio-guided or physiology guided, what is best, or whether it is equivalent, that has still to be determined. On non-STEMI patients, I think we definitely need more randomized controlled trials. But it looks like it's going in the same direction, complete vascularization in the early phase. Thank you very much, and I hope you enjoyed it, and thank you for attending.